I'm going to echo a little bit of what Ken said. Like, we're in this remarkable time. We have this governor that's paying so much attention to all of the things everyone in this room collectively cares about. Um, as Ken mentioned, I've been doing this kind of work for 30 years. I started as a marriage and family therapist and worked in community clinics for a long time, and then went to work for the county of Yolo and moved up. I know, hi, Yolo. Um, moved up the ranks there and got to be the director of health and human services, which included public health and behavioral health and social services and all of the things. And the county was just the right size. I always call it the Goldilocks County, not too big, not too small, just the right size. And for better or for worse, we all knew each other, those of us who had worked there for 20 years or more, and we learned to work together. And I think that's going to be like kind of the theme. Like, I think Ken's right. Our funding in behavioral health in California has more than doubled in the last decade, but our access to care hasn't improved at all. And so we have to work together to make that better. I don't think anybody can say anymore, especially in the children's space, sorry, that there's not enough money. I think we have to find a way to leverage all of the funding streams available to us and work together across systems to share data and to focus on the outcomes that matter in order to achieve those. The other thing I always try and say out loud in a room full of people, as scary as it is that I'm a woman in recovery. I got sober before I was old enough to drink. And I think that also drives my passion in this work to take care of little people and as they grow up. One little story before I hand it back to Ken is I worked in Yolo County long enough that I had children that were involved in child welfare that came to my perinatal day treatment program with their moms who were trying to get sober. And I spent every day with them, hours a day, got to watch them grow up and enter my juvenile justice system. And then I got to watch them grow up a little more and enter my adult criminal justice system. And then I get to watch them grow up a little more and have their own babies and enter my child welfare system. And so that's a curse and a blessing all at once, because it motivates you every day to do better by the people you love and care about. And it really took all of us across our systems working together, and it will take all of us across our systems working together to realize the vision of the Child Youth Behavioral Health Initiative and all the other things that are happening in this space. So I'm going to turn it back to Ken for a few slides, and then I'll be back up.
Again, holding in the back of your mind all that you've heard for the last few days and thinking towards implementation. We've been reimagining the system now intensively for the last 4 or 5 years. And the pathways, I think, began to be clarified a few years ago. We've described a children and youth behavioral health ecosystem. We've spent a lot of time thinking about that. The Children and Youth Behavioral Health Initiative, I think it takes a remarkable approach at thinking about prevention services, how we can intervene early, and it combines with the community schools efforts in a way that says, how do you administer and implement a system? So right now, funding stream for community schools, and then the Children and Youth Behavioral Health Initiative as an enormous jumpstart to the implementation of a series of comprehensive services. At the onset, and where is Elizabeth? Oh, way, appropriately in the back where she always hides, because she knows that I have to call out the level of leadership it took to help move all of this forward. And thank you, right? And it took somebody that wasn't on the practice side. It took somebody that was watching this from the law side and saying, this makes no sense. And to begin to pull people together from each of the necessary fields to say, how do we make sense? So when the Children and Youth Behavioral Health Initiative was announced, Elizabeth, Richard, many other folks, and a lot of young people and a lot of family members were brought together to say, how do we create an ecosystem that really works? And a paper that I think of it as the operating system behind Children and Youth Behavioral Health Initiative, that pointed out where the difficulties were going to be, that pointed out how the opportunities might occur, was created and has served, I think, in very powerful ways as a guideline for how to implement the Children and Youth Behavioral Health Initiative. The barriers were pointed out, and the biggest single barrier was, this is call and response. Okay, the biggest single barrier was collaboration. Was that we have a system starting at the federal level, moving to the state level, and then moving to the county level that was designed as a series of specialties instead of an integrated system of care. The most isolated of those systems was, there's not any educators in the room? Thank you. You said it. Thank you. I appreciate that. Little loud voice. You see, it reduces. Thank you. So the idea that education could then serve as a hub for all of these efforts, could serve as a catalyst, an entry point, and most importantly, the most powerful access point we have for early prevention, became deeply, deeply integrated into the Children and Youth Behavioral Health Initiative. The next barrier that was identified as a barrier that actually is relatively new, which is workforce. How many of you have had an easy time hiring in the last 2 years? A medium time hiring. How many of you been able to hire anybody in the last 2 years? Right? So the idea that if we're going to build a robust system, we have to build a robust workforce, and that workforce has to be really different. We had probably one of the, of all of the fields that I've worked in, we had among the least diverse workforces, particularly when it comes to social work and mental health. So the idea that the workforce had to be more robust, had to be supported, and had to be different became a key element of the ecosystem paper. And it had to say what we're going to do. And to that end, the fact that we had, through Child Welfare Council, through the efforts of many of you in this room, begun to develop a universal array of services became critically useful to think about, if we found a way to do this, how would we do it? Thanks. So, the universal array of services.
Okay, we talked about this a little bit. So Ken and I were on the Child Welfare Council, and we co-chair the Behavioral Health Committee, and this whole group of people came up with the universal array that I'm going to talk a little bit about. And when we came up with this document, it was a pipe dream, essentially. Like, we purposefully came up with this vision for what every child, especially our children that found themselves system involved, would need. And there was a lot of feedback, like, why would you put this out? Like, there's no way we can do this. Why would you guys put out this vision that we'll never be able to achieve? And the reality is, here we are a few years later, and I think that the majority of the things on our list can be funded. It takes creativity, takes working across systems, but I think we have a lot of hope. So I'm going to just run through some of the prevention and early intervention services, and then Ken's going to talk about his favorite thing to talk about, some of the deep end services. I mean, aside from his puppy, which is actually his current favorite thing to talk about. So we broke up our universal array document into different categories, from prevention and early intervention services to community-based supports, the tiered therapeutic placement options, and crisis services. And we think of these as like a pyramid, with prevention and early intervention as our foundation, right? That's, if we get that right and have enough of that dosage, then you can kind of go smaller to the those deep end and crisis services. I'm not going to spend a lot of time going through all the prevention and early intervention services in detail, but these are the ones that we identified. There's obviously a lot of other community practices that come up that work very well based on who you're serving or where you're serving. And so this in no way is meant to undermine any of those or discount them. This is just kind of what we came up with in this consensus document amongst the Child Welfare Council. I will say that right after the Universal Array document came out, FFPSA passed, which is a federal funding stream specifically for kind of prevention services to prevent children from entering into the child welfare system or kind of penetrating deeper into it. And so a lot of these services can be funded via that. There's also a prevention and early intervention component of MHSA. There will continue to be that portion of MHSA, even should the ballot measure that's proposed for March pass. So those are just a couple. I'm going to try and sprinkle in the potential funding streams for these as I'm going through, and we'll talk about them in a little more detail. To Ken's earlier point, we can't build enough beds, hospital beds or crisis residential beds to meet the need unless we build out our community-based supports. And this is on the children and youth side and the adult side. So yes, we're all talking about children and youth at this conference, but they all have parents, and a lot of their parents need a lot of help. And so this same kind of array of services, the same concept about building out these community supports is so critical to ensuring folks not moving farther into system involvement and crisis, really. I think some of the ones to call out here that maybe are a little different on the kids side than the adult side, or we call them different things, include these intensive home and community-based supports. And I think we can't forget substance use services for youth. It's kind of why I brought it up at the beginning, because our young people also struggle with substance abuse, right? It's not, so they need help, and those systems haven't been built out well in our state. I like to remind everybody that EPSDT is an entitlement program, because I think sometimes counties forget that you actually can't limit the mental health services that our children and youth on Medi-Cal get that need those specialty mental health services. And so, again, there's lots of funding streams that can be braided at the county level to ensure that those needs are met. I'm going to turn it over to my friend Ken to talk about the next few levels of care.
And before I jump in, I do, how many of you were here for the first day's presentation where Melissa Stafford Jones presented along? So most of you were here, okay? Because again, your reference point here, this is the Nothing New workshop, right? This is, how do you take these ideas and make them happen? And I thought it was perfect that Alameda County Office of Education and our lead, Sean, presented the implementation of the new option for rates to be able to provide these services in concert with Melissa, who laid out so beautifully, here's a way, here are the things that you should do. So coming back to the theme, here's something you want to do, and here's how you can actually get reimbursement for it, okay? So in each of these, I'll talk a little bit about not just what they look like, but some of the new avenues that we've been allowed to actually implement them. So way back at the beginning of my career, you could spend a tremendous amount of money if you put a child in residential treatment. But if you put a child in foster care or at home, there was no source of funding, no behavioral health source of funding, no child welfare. You could not fund it. Not only could you fund residential treatment, but you could fund it at more than 95% state and federal cost. There are very few of you who remember this. Now, any administrators in the room? Just, come on. So, Elise, you have a service that you want to provide. There is one where you have to use 100% of your local dollars, and another where the state and federal government will pay for 97%. Just guessing, which one are you more likely to use? Yeah, you like match. Yeah, yeah. How many of you like match? What do you think happened when 97% of the costs for residential could be paid for and virtually nothing was state and federal? So residential exploded. Of course it did. And then the state went, ooh, we have a problem here. So it went to 50% match. And then it went to, we're going to realign this whole mess to you all, and you all have to worry about it locally. And then folks started thinking differently. So the first development was intensive treatment foster care, and we have that at several levels. And intensive services foster care is a new term of art that we're using, where we're doing intensive treatment foster care, but adding additional services. And that by its nature has an integrated behavioral health component and a child welfare-based component. Enhanced intensive services foster care, we now have the ability to work with the state to do something called innovative models of care. Have any of you used that avenue to develop a specific service, an IMC rate? Interesting. Look around. How many of you are familiar with an IMC rate home? Look around. Camille, you need to raise your hand. You've done it. It just means you're not paying attention. Yeah, she's, I caught her. But nobody else. So you have, okay. Oh, of course you have. So there is a way that you can blend funds to provide an innovative model of care in the context of a home instead of in the context of residential treatment. That's what's important, okay? Then there's a even more enhanced version of that has 24/7 staffing, much of which can be provided through behavioral health billing. And then there's short-term residential treatment programs. Many of you are beginning to feel the impact of mobile response programs, and the mobile response programs that were rolled out through the FERS, Family Urgent Response or Foster Urgent Response System, that's designed to focus on foster care. But how many counties, how many of your jurisdictions have access to mobile response that will come to the school for urgent mental health response without police joining? Okay. How many of you had that 10 years ago? Okay. This is what I mean about the possibility of a different kind of system. Okay. Partial hospitalization programs. Interestingly enough, some of the private insurance companies have been more assertive in developing partial programs that will allow youth intensive services without taking them out of their home. Crisis residential, which is designed to be short-term, intensive service for stabilization and assessment and diagnostic, and then psychiatric health facilities, which is the highest level of care and can be locked. So the California Children's Trust has gone through and shown us different ways that you can use funding models to fund each of these components of service. I'm not going to go through this because Alex Briscoe isn't here, and even if Alex was here, I wouldn't understand what the hell he was saying. Yeah. There are times when he's talking, and I know that he's saying something really important, and really, I'm not being overly modest. I feel pretty good about this stuff. I feel like I know what I'm doing, and I'll just be sitting there going, "You've lost me. I'm guessing you've lost a couple other people in the room," but I think what's important here is that he has put a lot of thought, as have many other folks, into how you can particularly fund these high-level services in ways that are comprehensive and draw down a maximum federal match. Okay. This is you, right? Yeah. Oh, that's what was probably
Right. I'm going to go back to the last one just for a second, because I think one of the important the other big transformational changes that's happening in this space is this shift of a lot of the responsibilities that the counties have kind of shouldered over the past several decades, this shift to the managed care plans, right? The managed care plans are now responsible for a lot more in the behavioral health space, especially in those prevention early intervention kind of realm, or what we sometimes call the mild to moderate kind of benefits. And so this map, this resource that Alex has created, you can look at your county and kind of see how those resources, like what it should look like, what it could look like, and just kind of probably educate yourself to advocate better for resources within your communities. When I did my introduction, I failed to talk about my organization at all. So I'm the CEO for the Steinberg Institute. We were founded back in 2015 by now Mayor of Sacramento, Darrell Steinberg, as he was leaving the legislature. And when he left the legislature, he kind of looked behind himself and said, nobody's paying attention to behavioral health, right? I'm going to create this nonprofit, and we're going to do good work. And, fast forward almost 4 years later, and that's changed. There were 12 bills proposed in the year before we were founded in the behavioral health space, and this year there were more than 200. And as I mentioned earlier, the budget has more than doubled. So definitely a moment in time for addressing behavioral health. The stigma, I think, is reduced to some degree, and the resources are aplenty. I think COVID was a horrible thing for all of us to live through or to continue. Every time another blip happens, I'm a little like, oh God. And I think it might have been one of the best things that happened for children and youth mental health. It was horrible for the actual mental health, but it definitely raised the attention to the matter and the funding allocated for it. And I think a huge piece of that, 30% of our California population is on Medi-Cal, and a higher percentage than that of our children and youth. And the CalAIM initiatives that are coming out are really transformative, and I can't say it enough. It's like everything we've wanted in this field for the past over 30 years, and unfortunately it's all happening at once on top of the worst workforce shortage we've ever had. And so just gotta power through. We can do it. I have to talk about this because, as you may or may not know, my founder was the author of the Mental Health Services Act, Prop 63, which is a 1% tax on our millionaires. It generates over $4 billion a year now in California. Mind you, he had no idea it was going to do this great. But, we're almost 20 years in, and we haven't done a great job telling those outcomes, being able to tell the story about what those dollars have achieved. And so our governor, in his ultimate wisdom, has decided we need to look at that, those dollars, and make sure they're being leveraged to their fullest extent and focused on some of our biggest priorities. And so the proposal that will go to all the voters in March proposes that 30% off the top will go to housing. I don't know if anybody's been paying attention, but the number one issue for all of our voters is homelessness and reducing that. And so 30% off, and can't reduce homelessness without housing. So 30% off the top will go to housing. The next 35% will go to essentially wraparound services, full service partnerships for adults and youth. And then the rest will continue to be leveraged for PEI and the other community supports. I think that sometimes in the debate around this transformation, the reality of all of the other things happening in this space gets lost. And so people go, oh, you're taking all the money that we've been using for this, and we're going to have to cut services. And there's kind of this fear mongering that's been happening in the public discourse. And I think that's unfair, and I think it's not an accurate representation. We do have Child Youth Behavioral Health Initiative happening. We do have CalAIM happening. We do have our managed care plans responsible for so much more moving forward. And it is scary to have all of these changes happening at once, but I do believe that the vision of this transformation and the vision of leveraging all of these sources to maximize our federal funding and other sources is really inspirational and what we should have been doing all along. I think the only other thing I would say before I give it back to Ken is that I think if I were still Health and Human Services Director in Yolo County, I mean, it is an amazing time to be an integrated system. I think integrated systems are probably the best set up to make the most of all of that's happening in this space. And so I always encourage integration or collaboration across systems, especially. I think education should be working with behavioral health, and both should be working with child welfare and juvenile justice. And I think the more we all work together, the greater impact we can have and really prevent our children and youth of today from ending up penetrating further into the system. So I'm going to hand it back over to Ken.
Yeah, let's just do the rest of it here. Okay. So we've talked about some of this and some of the new policies, and I want to use the multi-payer fee schedule as an example of how we can talk and think about this. Where's our timer? How are we doing there? Huh? Good. Okay. So because y'all do need to get a little bit involved here. Because what I don't want is for y'all to go back to your corners and then have a kid where you know what you'd like to do or where you can't even think of what you'd like to do and not have the creativity because our funding streams have limited the way we think. We are trained like Pavlov's dogs in the way that we think. I got to do one of the first pilots with my team for wraparound, and she's long gone. She'll never know that I'm talking about her. This was a long time ago, but the first director I had for wraparound had this pool of money that she could do anything she wanted to do with. And we've had a kid that was really struggling. I mean, really struggling. And everybody was just, we don't know what to do. And so we pulled together everybody and said, tell me what we've tried. Well, we've looked at day treatment, okay? Categorically funded, highly specified, not individualized. Okay, well, all right, yeah, that didn't work. So we looked at residential in a 6-bed group home. Not individualized. Well, then what we tried was family therapy with a therapist that she hated. And I said, well, what about peer engagement? Have you done any peer engagement? Is there somebody she loves? Oh yeah, she has a best friend, but she's not allowed to see her because they escalate each other. Her thinking was so conditioned to the categorical funding streams that she knew she could use. Because in the past, they got in trouble if they didn't. Because they're providing all this service. And let me just, I'm going to say I, as the administrator, you can't do that. We can't bill for that. You cannot provide all of these services. And they learned that if they did, they got in trouble. And then when we had a funding stream that said you can unthink that, we had to start all over with how to do creative planning, where we included peers, where we included teachers, where we included family members, where we could do family finding and have it be fully funded, and where we could actually buy her dad a car, which we did. I know the fiscal people are going, you did it, oh, I hate the car thing, right? But we actually, the biggest problem was that her dad couldn't get to work. The family was struggling and close on the street. There was so much stress in the family. You've heard these stories before. So from a school perspective, when you start thinking about these new pay schedules, when you start thinking about the interaction between community schools and behavioral health, and when you start thinking about the fact, and any people that work for the insurance companies in the room? Good. That we're going to compel the insurance companies to do their share. Did I say compel? Yeah, I mean compel. I work for Just Advocates. I don't work for Seneca anymore. Nobody can get mad at me anymore. What are you going to do? Tell me I can't be an advocate? It's very liberating. Yeah. So to come to the table and have everybody do their fair share. So I want you to start thinking about the opportunity and how you can begin to execute. And the counties that are jumping out and saying, we're going to create a structure to be ahead of this. Yes, I'm bragging about you, Elise. And we're going to create a structure that's going to allow us to create deep partnerships with behavioral health insurance companies, regional centers who we haven't talked about. We did a little bit, but very little, that have to be deeply integrated, and other services and supports. That's what I want us to think about. You want to, because I sort of want to jump in and start thinking about, like, even case studies. I can give you one, but of places where you feel like you can't provide the services you need for a kid and a family, and how we might be able to do that differently in this model.
Yeah, I think the only thing I would add, I tend to kind of live a little more at the macro level, and I think what I've seen be really helpful is when the systems can align on their strategic plan, their vision for the outcomes they want to achieve, right? Like, generally, if you get around the table, everybody can agree on where they want their children and youth to land. And once you get there, then it becomes a little easier to figure out, like, whose responsibility is it for this? Or, oh, hey, did you realize, like, we could use our LCFF funding to provide match to do this? Or, we could work with, our health plan to help us with this situation, or we could work with law enforcement to leverage some of their dollars to do A, B, or C, right? So I think the other thing that we haven't spent as much time talking about today, but that's critically important, and I think maybe the most important thing as we navigate this moment of transformational change, is we have to keep those outcomes in mind in the service delivery, the services that we develop and deliver, because we should always be asking ourselves if we're making things better. I think, I mentioned that we haven't improved access to care, but the reality is, if you improve access to care and everybody gets crappy care, who cares? Like, that's not going to make anything better, right? Like, we have to ensure that the services we are providing for our children and youth and their families are helping them to achieve recovery and be fully functioning, happy, connected members of our society. I think that's all I would say.
Okay.
I love Elizabeth's clapping.
So,
I'm going to just go to the next slide.
okay. So, we really wanted to allow some time to engage you all. We want you to think about, are there situations that you feel are intractable, really difficult, and that funding has been a barrier in the past, and how we might do things differently in the future? They've got it down. I think they totally understand it, and they're all, thank you, Elise.
Oh, sure. I have frequently had the experience of having young people spend additional nights in juvenile hall because no one can find a residential or NPS placement that will take them. And it seems like there's both a combination of everyone sits around the table arguing about who's going to pay for it, but also that the people who actually can make decisions about placement are not at the table. Like the actual, it's like, we'll send an application to an NPS or an application. So that this is one of the places where I'm often confused and hearing other people's acronyms until I don't understand what's happening.
I think it's such a good point, and that situation only gets worse as they become adults. They sit in jail waiting for state hospitals, so we really got to figure this shit out. It's like really, like, so we literally are criminalizing mental health conditions or childhood trauma. I think making friends with your public defender, if you have I don't know what county you're in, but if you have specific public defenders that carry your juvenile justice caseload, they are often your best advocates, because it's like, you're not allowed to let kids sit in jail and not get their therapeutic and services that they require. I think, I mean, I'm a marriage and family therapist, so I always think relationships are the most important. And like I said, in the county I came from, we all knew each other for better or for worse. We, a long time, and you just kind of like, I had coffee once a month with my sheriff, even though we did not agree on most things, and most of those coffees we did not talk about work. But building that relationship was critical to when I needed him to do forced medication in custody for folks that were waiting to go to the state hospital and who were decompensating. And it's very much the same on the juvenile justice level. Is you have to get a bulldog who will fight for those kids and has the legal backing behind them, because counties can get fined and whatnot.
Richard.
Can I just elaborate on that a little bit and remind folks that in response to Elisa's question, which I think is relatively universal in a lot of counties, we wonder, how do we get the people with the gatekeeping authority to bless the innovative, adaptive solutions at the case level? Mm-hmm. You heard yesterday Placer talk about their Family Resource Community Collaborative that was facilitated by their parent with youth with lived experience. You heard Tuolumne talk about re-engineering their interagency placement committee. All 58 counties have an MOU in place that has interagency placement committee process built into that. Okay, we put that in there for this reason, so that you can look at your interagency organizational relationships, and when you convene IPC or whatever you call it, that's where those people need to be present, right? So when a young person can't get their service needs met at the child and family team level, it gets elevated where those gatekeepers with the dollars can say, yeah, I'll make that happen. Does that make sense? And if that doesn't work for you, then you got to deal with the interagency leadership team to get that IPC functional. There's a microphone.
Elizabeth?
So I'm a lawyer in the system, starting in child welfare, probation, and then education. The scenario that Elise just said is what got me talking. After my break, it was a child who I was sitting in an IEPT meeting, and he was highly dysregulated. He had been adopted to a family in a county that will remain unmentioned. And this is years ago. This is 10 years ago. And we were all having a fight. He was in the juvenile hall, and we were trying to find a placement for him. And all of the agencies were fighting over who was going to pay to place him. All the while, his mom was sitting at the table crying and saying, I really, really, really need help for him. He was a teenager. He was 17. She felt like he was a danger to her and the siblings. He had been in the past. And I kid you not, I was the lawyer sitting there for education. There was another lawyer there for dependency services. And I said, that meeting ended, that IEPT meeting ended with no resolution. Mm-hmm. I kid you not, no resolution of who was gonna find a place to put this child who was being released from juvenile detention. And the reason wasn't that there wasn't a place, to be honest. It was that we couldn't agree on who was gonna fund that place. After the meeting, the mom left crying. He was about to be released. I called the lawyer and I said, we're gonna figure this out. We're going to do a voluntary placement for him through the juvenile justice system, through the child welfare system, or we're going to figure out how to place him and share the costs. We're going to figure this out. And we did. We figured it out. We figured out how to stave off just what would have been a terrible situation, not just for that child, but his entire family. And that's when I started crying at my computer over why can I get what I need when I need it as a mass shooting and hostage survivor, and kids and families can't. It's because we have not teed up what Ken and Karen are talking about in many places, which is the relationships to build the universal service array for these children in these scenarios that, by the way, are not new. These are not new scenarios. I've been doing this 31 years. They have been happening for the entire time I've been doing it. So we've got to sit down, partner together, and figure out, in the scenario that Elise just said, what are we going to do? So that when it happens again, and it will, you already have it figured out. And the decision makers have to be there. And I always say, we cannot create the conditions for success for children and youth and their families in a vacuum. Education can't do it by itself. Child welfare can't do it by itself. Juvenile justice can't do it by itself. We can't do it. We have to do it together. So I just thank you for that question.
Well, and now I'm going to give you the wonk answer, okay? So, and any of you know the term FITFO? Good. Okay. I'm not going to tell you what it is, but you'll think about it. But it starts out with figure it. So let me tell you what was. Thank you for that little giggle. Figure it the heck out. Oh wait, I didn't spell well. So there are some things in what Elise talked about that have been left out and steps. So what I'm going to do is take. So in the past, the answer was every systemic incentive was stacked against finding a solution for that youth. We used to have this meeting in one county that shall remain unnamed that I called the Monday morning misery meeting, where we would bring a kid to the table and each of the systems would argue over whose funding responsibility it was. We don't have to do that anymore. So we take this young person. There's a, and I'm going to reveal my bias because it's the sector I'm from. Who are the providers in the room in the discussion? Oh, was there a provider in the room? Because usually there's not. Usually it's in only the government entities in the room. So I would have called Camille into that room and I would have guilted the hell out of her. I wouldn't have tried to force her. I would have just talked to her about that kid. And then I would have looked through my possible funding streams. So I can use wraparound and family to do family finding to reach out and see if I can develop a relative support network. I would say, is residential the best solution here? Because this is a child that might need a more individualized solution, and I could do an individualized care program. This is a funding stream through child welfare and juvenile justice where you can actually do a separate individualized funding plan just for one child. And then I would bring behavioral health in and say, we may need, in order to support this provider, one-on-one services during waking hours. And then I would bring the RAP team in and say, we may need to staff overnight. And then I would say, if I did all of that for and with you in deep partnership, and Camille, I know this is a volatile situation. If something bad happens, I will have your back. Okay? That's a completely different approach to let's send out 17 packets and see which residential provider is not risk averse. I'm learning to modify my language as an adult. Is willing to take this child. But the planning, this is what our funding streams have done to us. The planning takes us to funded programs rather than individualized treatment. And now that we have the opportunity to really individualize, to say, there's no family member that will take a child. Really? There's no family member if we could support them at a level that allowed them not to work? I know that's a radical idea, but we'll spend $300,000, $400,000 a year on a residential treatment plan, and we won't support a sister, an aunt, a cousin to stay at home for 6 months until a child stabilizes. All of these are opportunities with these new funding streams, and Richard has just given me the sign. Thank you all for being with us on this journey.